Welcome to Approach to ABGs Part 13, the non-anion gap. We're going to explain why a non-anion gap exists. We're going to compare it with anion gap versus non-anion gap. And we'll give you a short differential diagnosis of non-anion gap acidosis. A couple quick abbreviations. Anion gap metabolic acidosis is often called AGMA, and the non-anion gap is called NAGMA. So you might see these abbreviations, and this is what they mean. So just to review, this is anion gap metabolic acidosis. We have new acids added to the blood, which reduces the bicarb and creates a metabolic acidosis with an anion gap, because these new acids are not included in the equation. And the anion gap is like a footprint of the metabolic acidosis. And this is from our previous podcast. Acid is dissolved in water, it dissociates, this extra hydrogen ion concentration is added to our standard acid-base equation. Hydrogens go up, shift right, bicarb goes down, and you have metabolic acidosis. And then using this in the anion gap equation, remember the acid has a negative charge, so it becomes an anion, and it's not calculated in the equation, but we have bicarb being reduced. So this is going to result in the anion gap being higher because the negatively charged acid is sort of sitting there invisibly, but it's not part of the math. So this is just a review of the anion gap, and we're going to compare that with a non-anion gap. So when there's a non-anion gap, there are no new acids introduced into the blood. And it's actually a pretty simple process. One of two things happens. Either new chloride is added, typically this is from an intravenous, or bicarb is lost from the body. And this is going to be renal losses, so the kidneys will lose bicarb, or they could be GI losses, typically diarrhea. So chloride and bicarb are in balance with each other. When one goes up, the other goes down, and vice versa. So let's take a look and see when chloride is added to the system, we're going to see an equal amount of bicarb being reduced. They balance each other off electrically. And so if you go up by 5 on the chloride, you're going to go down by 5 on the bicarb, and the math doesn't change. The anion gap remains 12. Similarly, if you have nothing else happen other than you lose bicarb out of your body, so this is not the case where we have a new acid, but you just simply have loss of bicarb out of your body, the chloride will compensate and go up. And again, the math remains the same. So when we have these primary changes occurring, there is no change to the anion gap. It remains 12. So non-anion gap acidosis, or a NAGMA, in all cases, the chloride and the bicarb balance each other out. So when you add them up together, it stays the same, and there's no change, no increase in the anion gap. There's no new acid being introduced. And typically, the non-anion gap processes are not as dangerous as the gap processes. So when you have a new acid introduced into the body, it's usually a more dangerous process. Of course, any process that is really severe will be dangerous, but as a general rule, gap or AGMA processes are more dangerous than NAGMA processes. Differential diagnosis of a non-anion gap metabolic acidosis occurs when you add chloride, and this is typically through intravenous fluids and normal saline, believe it or not. And if you don't believe me, go look at a bag of normal saline. It has a pH of 5.5. It's really acidic. And if you have normal saline with dextrose, the pH is 4.0 or 4.5. It's super low, shockingly. And then the other form of chloride is also with an IV, TPA or TPN, which is basically total nutrition being given intravenously. And loss of bicarb is the other category, diarrhea. Remember, you've got all this acid in your stomach. It needs to be neutralized, so your duodenum secretes all this bicarb. And if you have diarrhea and you don't reabsorb that bicarb, it exits your body and you lose bicarb. And then there are some renal conditions. One of them is called renal tubular acidosis, or RTA, and you can lose bicarb in the urine as well. So these two major categories, addition of chloride or loss of bicarb, are the most common causes of a non-anion gap metabolic acidosis.